Hi, I'm Vijay Ramanan. I'm a cognitive neurologist at the Mayo Clinic in Rochester, and very happy to share some perspectives on some rational approaches to testing in the cognitive neurology, MCI, and dementia setting. I think we can start the discussion by recognizing it's a real positive in the field to have additional tools at our disposal to help with diagnosis. Getting an accurate diagnosis in the cognitive neurology space is the first step to defining expectations, management options, and other aspects of counseling. Some of those new tests play roles in addition in potentially treatment monitoring moving forward. There are, though, naturally questions that can arise when there are many tools: when to use them, how to make an interpretation. So what I'd hope to do today is provide a perspective on how to rationally apply some of the tools that we use very commonly in this part of neurology. And bear in mind, this isn't meant to be overly rigid or a formula. Patient care doesn't follow rigid formulas, and clinical context is always going to matter. But what I'd hope to do is share some cases that provide examples of good use and maybe less than good use of some of these new tools. Bears our discussion to start by noting, even before talking about laboratory or imaging studies, there are some key parts of evaluations in cognitive neurology that are essential. History and office examination are parts of those essentials. This can include any type of standardized cognitive screening exam. At the Mayo Clinic, we utilize the short test of mental status. There are other tools that accomplish the similar thing, ensuring that individuals with cognitive symptoms don't have an obvious systemic reversible cause for those symptoms, such as thyroid dysfunction or vitamin deficiency, ensuring there's not a structural brain abnormality like a tumor, many vascular impairments, strokes, bleeds that can cause cognitive symptoms and therefore demand different aspects of management and other testing. Within that basic evaluation of cognitive symptoms, plasma p-tau217 can play a role if Alzheimer's disease is plausibly in the differential. Recall that Alzheimer's disease most commonly presents with gradually worsening short-term memory problems that gets progressive over time and can start to involve other cognitive domains. That's not the only way that Alzheimer's disease can present, nor is Alzheimer's the only thing that can present that way. But if that's the syndrome and Alzheimer's disease therefore is a possibility, assessing plasma p-tau217 can be a very helpful step in the evaluation, and that help can occur in a variety of clinical settings. We use it very commonly in a subspecialty cognitive neurology practice. This can also apply in general neurology and primary care settings. It's important to keep in mind there are some settings, patient settings, where use of that test may not be the most appropriate. For example, if individuals may have cognitive symptoms but are under the age of 50, or if individuals are asymptomatic, we don't have good data to guide how to interpret profiles of this blood test in those settings. But there are other use cases where that p-tau217 can be very helpful. I'll share an example here. Let's think of an individual, 78-year-old man who's had 4 years of gradually worsening cognitive decline, very heavily affecting short-term memory with repeating questions and conversations. This individual is starting to need help with some daily activities. There is a setting of some chronic back pain, including prior surgeries. As part of the medical history, this individual is also on a blood thinner for atrial fibrillation. After obtaining that history, you complete a cognitive assessment in the office, and they do struggle on that assessment, corroborating the history of cognitive symptoms subjectively. You do some evaluations to assess for those reversible systemic or structural intracranial causes of cognitive impairment and don't have an explanatory finding on those tests. So we have a memory predominant, gradually progressive cognitive syndrome in an older adult. This is a setting where Alzheimer's disease plausibly will be part of the differential. This is also a setting, therefore, where a plasma p-tau217 can help as a rule-in or a rule-out of Alzheimer's disease, because a positive or an abnormal result would add confidence to a suspicion that you have in the differential diagnosis about Alzheimer's disease being the cause of the memory symptoms. There aren't For example, obvious confounding factors which could impact your ability to interpret the result of this test. For example, individuals with significant chronic kidney disease, particularly stage 3B and worse. There can be difficulties in interpreting this test because that kidney disease could result in artificially inflated levels of p-tau217 in the blood. And importantly, as I mentioned earlier, there are non-Alzheimer's causes for this clinical syndrome. So a negative p-tau217 in this setting would make it very unlikely that Alzheimer's disease was the cause for this patient's symptoms, and then might orient one to thinking about alternatives such as late, which is another neurodegenerative disease that can affect memory and thinking. Now, note, we do have additional tools, biomarker tools, to assess for Alzheimer's pathophysiology in a patient like this, including CSF biomarkers. Obtaining that type of a test wouldn't be wrong or inappropriate here. However, when you consider the context of having to manage the anticoagulation around a lumbar puncture in this individual, potentially the technical challenge of completing a lumbar puncture in a person with prior back surgeries, that could make those CSF biomarker assessments a little more challenging to obtain, and here's a setting where plasma p-tau217 is an excellent tool to have in the toolkit. In our early experience in a cognitive neurology subspecialty setting, we found great value in having this test, again, as a rule-in or rule-out for an Alzheimer's disease diagnosis. There's some benefits as a neurologist that I can point to, including the fact that the cut points for this test are really guided by high-quality research, looking at population-based samples where we try to hit an optimal sensitivity and specificity at that level that's really required in order to rely on a blood test for getting an accurate diagnosis in individuals with cognitive symptoms. We also really enjoy the benefit of the quick turnaround time of this test, to be able to see a patient early in the week, make an assessment clinically, and do other tests, including this plasma p-tau217, and have an answer within that week, sometimes even within the same day or two, is a real advantage to patient care. We know that there are other plasma biomarkers for Alzheimer's pathophysiology out there. There are some relative weaknesses to keep in mind about those biomarkers, including the fact that when amyloid species are part of the measurement, there can in some cases be concerns about the stability of measurements for those species. There can be extra processing requirements given the tendency for amyloid protein to stick to certain types of tubes, which could affect the ultimate interpretation of results. And of course, where and how you study and develop cut points for these assays is going to impact the applicability in real-world practice. So without getting too far into the weeds there, I would simply say that we've had a very positive experience with the plasma p-tau217 in our clinical practice. Now, one addendum to this discussion, the case that I shared, we use that value, that plasma p-tau217, as a factor to help with diagnosis, a rule-in or a rule-out. There are ongoing discussions in the field about plasma biomarkers and their potential utility in evaluations for eligibility for new disease-modifying therapies. In general, the balance of the subspecialty field currently favors blood tests not serving as a standalone for those eligibility assessments. However, those blood tests can certainly be a part of initial evaluations in screening and triaging in order to identify potentially appropriate candidates for new anti-amyloid therapies to get additional testing on a confirmatory basis. There are also discussions and ongoing research in the field about certain clinical settings where there may be an appropriate use of a blood biomarker as a standalone measure. This will continue to evolve with additional research and additional developments in this space, but I hope that provides a bit of context. Now, one other addendum to the setting that we mentioned, that was a very AD-focused setting in the presence of a syndrome that's highly suggestive of Alzheimer's disease. One's approach to testing can often be a bit more narrow and therefore take advantage of p-tau217 as one example. There are other scenarios which may not be so narrow and therefore may argue for a broader differential and as a result potentially broader testing. So if there are clinical features that suggest Non-Alzheimer's causes ought to be high in that differential. If the syndrome itself is less typical, for example, very rapidly progressive in comparison to most cases of Alzheimer's disease, or if there's a subacute course potentially pointing to an autoimmune or other primary neurologic causes, at least belonging high in the differential diagnosis, this naturally may open the door to thinking about, for example, cerebrospinal fluid testing or imaging testing. I'll share a case where CSF Alzheimer's biomarkers, I think, play an optimal role in evaluation. So let's envision a 56-year-old woman who's had 2 to 3 years of progressive cognitive decline. That decline affected her ability to work. It was yielding impairments and mistakes in activities at home. There's also a history of acting out dreams at night. This patient, similar to the first case, showed impairment on cognitive testing in the office and also had a tremor on exam. Initial testing to screen for blood systemic abnormalities or structural intracranial explanations was unremarkable. Now, plasma p-tau217 as part of an evaluation here would not be a wrong choice. This setting could include Alzheimer's disease as part of the differential. However, there's a couple of factors which could argue in favor of a cerebrospinal fluid biomarker in this case. For one, the presence of dream enactment behavior and tremor on exam are features which could raise the possibility of Lewy body disease as belonging in the differential diagnosis. Obtaining a lumbar puncture in this setting would allow for testing for an alpha-synuclein biomarker alongside the Alzheimer's disease biomarker. So point being, what other elements of the differential are present? What other elements of the background medical situation are present are really primary drivers of a choice here in terms of the optimal biomarker to choose. And bear in mind, if this person is seeing a subspecialist or other clinicians, there may be value in additional diagnostic testing. For example, we have imaging biomarkers which can point to the presence of Alzheimer's or related diseases. For example, on MRI scans, there can be atrophy in particularly the temporal and parietal parts of the brain in Alzheimer's disease that can help to support or rule out a diagnosis, again, appended to the clinical situation and taking the result in its appropriate context. In our subspecialty clinical practice, we use glucose PET scans very frequently. On the top here is shown a normal example of a glucose PET scan. On the bottom, an abnormal example, the areas with bright color indicating hypometabolism, pointing to neurodegenerative changes occurring, again, predominantly in the parietal and temporal regions, elevating Alzheimer's disease as a possibility in this case. There are also imaging biomarkers to assess for the amyloid plaques and tau tangles which build up in the brain in Alzheimer's disease. And like any other test, there are going to be more and less appropriate use cases for these. Ultimately, it comes down to the clinician making a judgment. How confident are you in the diagnosis as you sit today with the information at hand? What type of access do you have to these additional tests? How much value would they add to your decision making or to your diagnosis, and potentially even reimbursement and payment issues? All of those things are going to impact when these tests might be utilized, but it's a positive to have these tests and to be able to place their relative strengths and weaknesses in context. There are non-Alzheimer's and non-Lewy body conditions which may require alternative testing. As an example, let's consider a 62-year-old individual who's had 6 to 8 months of significant declines, was in a normal state of health within that time period, and has transitioned to being very forgetful, requiring significant amounts of help day to day, meeting criteria for a rapidly progressive dementia syndrome, displays fairly significant impairment on office cognitive testing. Again, no clear-cut explanations from initial testing looking at possibilities that ought to be checked in any individual with cognitive symptoms. In a rapidly progressive dementia setting, this warrants appropriately a broad differential diagnosis and therefore can favor the use of cerebrospinal fluid testing to assess for elements of that differential. That differential, in this type of case, could include prion disease. We have an RT-QuIC test, which is generally acknowledged to be the best available test, biomarker test for prion disease diagnosis in life. There are other causes of rapidly progressive dementia syndromes, including rapidly progressive, less typical cases of Alzheimer's and related diseases. Again, we have some biomarkers for those diseases that can be assessed in the spinal fluid. Autoimmune encephalopathy is another condition, or relatedly a paraneoplastic encephalopathy, another condition that ought to be part of the differential diagnosis in this setting of a rapidly progressive dementia. One can therefore assess for signs of inflammation in the spinal fluid and/or signs of autoimmunity in the spinal fluid and the serum as a way to assess that possible element of the differential. So point being, in this setting, broader testing valued because of the broader differential diagnosis, and cerebrospinal fluid testing offers a good medium to pursue that. So the last element of this discussion, I'll transition to talking a bit about genetics, because this does rear its head in neurodegenerative conditions. Helpful to know as a foundation that most cases of Alzheimer's and related neurodegenerative diseases are not in fact genetic, and let's dig into that in a moment. Obviously, our genes influence risk of developing a whole host of conditions. However, for most cases of AD and related conditions, that genetic influence is nuanced. It's multifactorial. It's not driven by one specific gene that's a predominant effect. It's a combination of genes, some of which may promote risk, some of which may have protective effects, and all of which sit amidst other risk and protective factors in one's environment and lifestyle. Rarely, Alzheimer's disease can be truly genetic. There are 3 genes that are known to have mutations that can cause generally early, very early onset, typically in one's 30s, 40s, or early 50s, and often with a very strong familial pattern. And in that type of setting, there can be gene panel testing to assess for those gene changes. Now, in most cases of Alzheimer's disease, we know that the APOE E4 allele is a risk factor for developing Alzheimer's disease, but it is not necessary or sufficient for developing the disease. So presence of that allele or that gene variant is associated with a 2 to 3 times increased risk if there's 1 copy of E4, or an up to 8 to 12 times increased risk if there's 2 copies of E4. But again, because one can develop Alzheimer's disease without carrying APOE E4, and because individuals can carry 1 or even 2 copies of APOE E4 and never develop Alzheimer's disease or another memory problem during the course of their life, we don't recommend testing for APOE outside of a very narrow circumstance that I'll talk about in a moment. In contrast, in frontotemporal dementia cases, there is a relatively higher predilection where even in the absence of a clear-cut family history, extreme young onset, there can be cases, we think upwards of 10% of cases, that end up being due to a gene change. And so this is a setting when there is a frontotemporal dementia diagnosis where some aspects of counseling might warrant a discussion about considering gene panel testing to look for those changes. And again, if there is a very strong family history, if there is very young onset, if there are particular features, for example, the presence of both FTD and concomitant motor neuron disease, those could nudge one even more strongly to thinking about those tests. Now, the one use case in the setting of Alzheimer's disease where we do recommend testing of APOE E4 allele status is not about diagnosis. It is specifically in the setting of thinking about treatment with anti-amyloid therapies. The reason is that those anti-amyloid therapies, medications like lecanemab and donanemab, can cause a side effect known as ARIA. This refers to edema or swelling in the brain, or microhemorrhages or siderosis, bleeding over the covers of the brain, that can develop in the course of that treatment. In short, those treatments, while removing amyloid plaques from the brain with the aim of slowing progression of the disease, they can also make the blood vessels more leaky. Presence of the APOE E4 allele, and in a dose-dependent fashion, increases the risk of developing that ARIA. So for patients who are considering those anti-amyloid therapies, this is the situation where APOE E4 allele testing is important. Once again, in patients who are cognitively unimpaired, including those who have a family history of dementia, at this point in time, there is not a recommendation to go testing APOE E4 allele status. It's also important to keep in mind APOE E4 allele status really is not a factor in diagnosis of Alzheimer's disease. Remember, we have other tools for that: blood biomarkers, CSF biomarkers, imaging biomarkers, all appended to the clinical setting. But in risk stratification around new treatments, APOE testing does have a role. So last mention, I just want to clue everyone in to the fact that this is a rapidly evolving space. And that's a really good thing for our patients and for the field. So it's important to keep in mind there will continue to be evolutions. In addition to the drugs that we have to treat Alzheimer's disease, there will be, many of us feel, additional drugs coming to the market over the coming years. We hope additional drugs to treat other non-Alzheimer's neurodegenerative diseases as well, and alongside those, additional biomarkers to help support or refute diagnoses of those neurodegenerative diseases. There may be developments of specific biomarkers that become important in treatment monitoring, and all of this picture is potentially leading to a setting that's much more evocative of what we see in other common medical conditions like high blood pressure or high cholesterol or diabetes, where combination therapy approaches follow combination laboratory and other testing for diagnosis and management to really be linked, targeting multiple mechanisms on an individualized basis. So in a rapidly evolving space, I hope that this discussion provides a framework, a rational approach, and some principles that can be put into use in thinking about new and emerging and high-quality tools that we have to help support diagnosis and, in some cases, treatment decisions around Alzheimer's and related neurodegenerative diseases. For one, plasma biomarkers offer great convenience and access. Turnaround time can be a real important thing for patient care. There are settings where those blood biomarkers can be highly valuable. There are settings to keep in mind, including background medical conditions, which can affect interpretation. In the setting of conditions which demand, syndromes which demand a broader differential diagnosis, cerebrospinal fluid testing and the breadth of measures that can be assessed in the CSF offer a rational approach to assessing cases like rapidly progressive dementia. And there are genetic testing options, but it's important to understand, for many reasons, appropriate use and less appropriate use of those options. So I hope this provides a foundation for discussion, and I thank you again for your attention.